We are honored to once again be joined by our good friend and colleague, Michellene Davis, President and CEO of National Medical Fellowships. Good to see you, Michellene.
It's better seeing you, my friend.
And also let me say that Michellene Davis is the vice chair of our board of trustees at our not-for-profit production company. Michellene, the website for National Medical Fellowships is up. Tell folks what it is and why it matters now more than ever.
Oh my goodness. Thank you so much for that. See, National Medical Fellowships has for the last 80 years been addressing the physician shortage. It is that thing that people are feeling right now. This crisis is not coming. It is already here. And so NMF has been really working to remove the financial structural barriers by providing scholarships, financial aid to students who are in medical school in order to assist them on making it through medical school. We also, of course, give them a fantastic community to be a part of, mentorship, networking, programmatic and professional development, just to ensure that they make it through and remain in the profession.
Now, your organization does all it can as a not-for-profit. We are as well, as you well know. But you never can solve the entire problem and the crisis as you described. Describe the crisis. I'm reading a section on the piece from NJ.com. New Jersey already has one of the worst primary care shortages in the country, according to the New Jersey Healthcare Quality Institute, great organization. The state only has 17 primary care physicians per 100,000 residents, among the lowest concentration in the nation, and a fraction of what is needed. How the heck, Michellene, did we get to this point, and how do we close that gap?
So much of this really is a multifaceted background. But what I will tell you is that there are really two primary things that for me really stand out. One, there is a GME cap. That is a cap on the number of residency slots across the country. It is not set.
Sorry for interrupting. GME, graduate medical education.
Yes, okay. Graduate medical education. That's why I said residency slots, right? And so it is, once you complete medical school, there's this fantastic day. It is match day. You find out where you have matched across the country and into what specialty. One of the issues there, my friend, is that there was a GME cap that was placed by Congress, right, back in the 90s. And as a result of that, that cap makes certain that the number of residency slots available remains at a certain level, right? It is the level that lots of national organizations have been advocating needs to be increased for some time. That being said, it has not been. And so it continues to be there. But in addition to that, another aspect that has led to the exact statement that you just gave, that data point, has a lot to do with the expense of medical education, right? It is so expensive that when individuals graduate, they oftentimes go into specialty instead of primary care because the primary care pay rate is lower, right? And so you just talked about the fact that there are only 17 per 100,000 residents. That is, in fact, not just an issue, that is at a crisis level, Steve.
Is it worse? Now, those statistics, I mean, just imagine we're talking about 17 primary care physicians per 100,000 residents. Is it worse in minority communities?
So, my friend, I will tell you this, that, in fact, it is. But this is a topic that affects individuals no matter where you live. I don't care whether or not it is Millburn and Short Hills or whether or not it is Camden or Absegami. It runs the gamut and affects you at every level. And this is what's interesting. If folks do not believe that they are feeling it at the crisis level, I need them to think about this. That about 10 or 20 years ago, when they called to get a physician's appointment, when they called to get their doctor's appointment, they were given it, in relatively short stead. Now you can call to get an appointment. I called once in February and I received the date of October 27th. And that, my friend, stuck with me. Yes, my primary care physician is a friend. She's a friend. And I could not get in to see her until October.
So your organization, doing all you can to promote minority professionals going into the field of medicine. But let me ask you this, from the straight economics that you just laid out, going into their specialties, do you blame, there's no other way to say this, do you blame a medical professional, a doctor who says, I'm going to go where I need to go to make money because I have to pay these these medical school bills, plus I got to make a living for my family. You don't blame them for that. So how do we change
Yeah.
the economic incentives?
Yeah. So, Steve, let me say this: two things. One, my organization actually welcomes all comers. It is based on income eligibility, right? And so, if you have eligibility based on your income, if you are from a community that is at a lower economic state, and then if in fact you have a demonstrated track record of a commitment to community health, we welcome you in. So I just want to make certain that I clarify that. The
Got
additional
that.
aspect, yeah, yeah. But I will tell you
Thanks for
this:
that
our alumni,
clarification. That clarification is important.
you got it. But I will also tell you, though, that we tend to garner and attract students to apply for our scholarships who are already dedicated to community health and well-being, right? That's that demonstrated track record. And through recent research that we've done, just analyzing our own alumni database, we have found that upwards of 70% of them, right, literally choose to serve in communities that are at they are socially vulnerable communities, right? And so as a result of that, we are undoubtedly really rushing in when others are rushing out in that regard. But this is what I will say. When you say, well, certainly we do not fault them, absolutely, positively not. And I will tell you this, that for a long time, the parameters of the system actually worked to try to incentivize individuals to serve in communities, right, that are really high in the social vulnerability index. And unfortunately, recently, as a result of what I call the love letter to America, which was HR1, we've seen some shifts there, some shifts that, my friend, are going to affect everyone, no matter where they are. And people may think that they will not, but they will, right? And so why do I say that? I say that because that which other folks call it the big, beautiful bill did some really tricky things in medical education. First of all, our typical scholar is oftentimes first generation medical school, first generation college, first generation some high school graduate, right? So if you are in that position, there is a high likelihood that your family cannot support your educational pursuits. So you're already graduating from undergrad with a significant level of debt. Then when we look at medical school, which, as you know, ranges between, oh my gosh, $70,000 to $200,000 worth of debt. We are seeing individuals graduate from medical school with a debt load of upwards of $600,000. What would you expect that person to choose in order to be able to make up for that debt and attempt to thrive in a profession, right? I'm likely going to look at, so what actually, right, pays the most and also aligns with my values. There's a likelihood that I'm going to go into orthopedic surgery. There's a likelihood that I'm going to, right, choose to go into dermatology. These specialties pay higher than a primary care physician.
Wow.
Right? Right? And Steve, if you permit me to, I'd love to talk to you about, right, some of the key aspects of the impact on medical education that was literally in HR1, right? So we saw literally the elimination of what was referred to as Grad Plus loans. These were loans that were really special because of the fact that they were so incredibly low interest. They've now gone away. Then we literally had caps on the ability to borrow from the federal loans, which again are very low interest. So if we see that now it's capped at $50,000 per year with a lifetime limit of $200,000 for professional school, medical school is the highest, most expensive professional school education there is. We just walked through, right, what that debt burden can be. So what we know about that is that when we have that cap, individuals who have this indomitable will to aid their, humankind, their neighbor, their friend, and literally pursue medical education, they're being driven now into higher private debt because they still have to make up for that loan shortage, right? Because now it's capped. So that means that they're going to be driven into privatized loans, which have much higher interest rates. I'm not telling you anything that you don't know, but it adds to that debt burden. And so then we also have significant changes to the public service loan forgiveness and deferment benefits program, right? This used to permit individuals to go and serve in underserved area and have loan forgiveness.
Michellene, let me follow up on this. What you just described is a complex, multifaceted crisis problem. that did not happen overnight. And you also make it clear that HR House Resolution 1, the big, beautiful, blah, 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 whatever people choose to call it, the impact and the implications of it, that may or may not be the intent of those who create it. Who knows? It's irrelevant because the reality is what you just described. What do you believe it will take in terms of the political, social, cultural will to begin to turn this around? Or is this the track we're on?
I will tell you that right now, the American Medical Association warns that these high educational costs are already the primary barrier to medical school, right? They've already indicated that these restrictions will exacerbate the projected shortfall significantly. We are right now at a time when we are incredibly divided as a society, which breaks my heart. But when you ask me what it will take, it will literally take the understanding that we are all intricately interwoven. This is not something that is going to bother those folks over there. Americans are living longer, but we are living sicker. Steve, who will care for us, regardless of socioeconomic or religious or cultural or ethnic differences, regardless of all of that? Who will care for you when you are at the age? Of course, you won't look that old, but nevertheless, at the age where you need to have significant management of chronic health conditions. Who will care for those that we love?
To what degree does this political, cultural, human divide, the polarization that's going on? Are you with them? Are you with blue, red, MAGA, not MAGA, whatever? What has that done, that polarization, as it relates to the trust/mistrust in public health, information about vaccines, information about best practices, information about the things you're talking about? That's not political, but it hasn't always been this way. Or has it and I missed it?
So I will say this. I think that everything that we are seeing right now was always actually there. It is just bubbling up to the top, my friend. It now has a microphone rather than a whisper campaign. And so we are seeing it and feeling it. And unfortunately, so are our physicians and our clinical research scientists and our medical students, right? We see talented students every day who have the passion and ability to serve in community, but they face significant financial barriers to entering the profession. One of the additional barriers that they're facing right now really is this lack of a trust and belief in science, right? Right? So we're saying, oh my, we have hit crisis status on our physician shortage. Please come into a profession that is being questioned, that is being challenged every day by influencers. Listen, I'm not anti-influencer. I just want you to have a background in science, perhaps a degree in medicine, right, in order to tell me what to take, what to do, and to be listened to.
And by the way, excuse me for interrupting, Michellene, it's not just physicians, but nurses as well.
Oh, absolutely. Listen, have you taken a look at the rate at which nurses are leaving their profession? You got it. You got it. So the shortage is being exacerbated, and this is a healthcare workforce shortage in two primary ways. Yes, we do not have enough folks going into the professions, but my friend, we have individuals who are electing to leave the profession way before the age of retirement.
Wow.
Burnout of this workforce is significant, and what you just described is one of the reasons and the rationales as to why. When you enter a space
where people don't respect what you do, you're saying you're following best medical science, and people are like, no, I'm not with that.
Right? Listen,
and I think you're the enemy.
So that part, right? Because it's one thing to say, well, I looked it up on Google, and this is what my sentries say. It's another one to say, no, I don't trust you because you have a medical degree. It's another one to say, right, well, I don't trust that science. That is a difficult thing to come to, right? And the fact that there's already a backup against it. My friend, if we do not get on the same page as an understanding that your well-being is connected to my well-being and that we better get in this together, we will unfortunately all perish apart.
And by the way, check out the interview that we did with Dr. Perry Halkitis, who Michellene knows well, from the Rutgers School of Public Health. Perry's been studying public health for years. In that interview, he talks about what we learned during COVID, and also he goes all the way back to the HIV/AIDS crisis as well. Michellene, just got 20, 30 seconds. You remain optimistic because you're a person of God and person of the church. Are you optimistic about this?
Listen, I have an audacity of hope. And I have it because every single day I get to deal with medical students and those who are hoping to become physicians and see and hear from them not just the passion to do so, but Steve, the absolute brilliance. NMF is going to continue doing what we've done for the last 80 years. We're going to continue addressing the physician shortage by bringing the best and the brightest to its forefront.
Michellene Davis, President and CEO, National Medical Fellowships. Thank you, my friend. Appreciate it.
Thank you.
I'm Steve Adubato. That is a very smart professional. We'll see you next time.
State of Affairs with Steve Adubato is a production of the Caucus Educational Corporation. Funding has been provided by EJI Excellence in Medicine Awards, a New Jersey Health Foundation program, PSCNG, the New Jersey Education Association, NJ Best, New Jersey's 529 College Savings Plan, New Jersey Sharing Network, Englewood Health, the Adler Aphasia Center, Delta Dental of New Jersey, and by NJM Insurance Group. Promotional support provided by Insider NJ and by NJBIA.
Hey kids, PBS Kids and Delta Dental want you to have a healthy smile. So here are some tips for you to remember. Number 1, eat plenty of crunchy fruits and vegetables. Number 2, brush your teeth after eating sugary snacks or drinking sodas. And number 3, drink lots of water to wash away food particles. When your teeth are happy, all of you is happy. From PBS Kids and Delta Dental, have a healthy smile.